Please.
Thank you, Dr. Seth. And my job this morning is to talk about pulmonary hypertension in left heart disease. Some portions of the talk may sound very, very basic, but a large part of this talk is derived from the proceedings of the World Symposium on Pulmonary Hypertension, which was held in towards the end of 2018. This first slide shows how common is pulmonary hypertension, type 2 pulmonary hypertension, that is hypertension due to left heart disease. The incidence may vary. This is from the European Society of European Respiratory Society. The incidences may vary because we all know that the criteria for diagnosis, the way we make those measurements, and the populations, they all differ. So the incidence of pulmonary hypertension due to left heart disease may vary in literature from anywhere between 60 to 80%, and this is the one that I've quoted here, but this is the commonest cause of pulmonary hypertension overall. So that is the first point to be remembered. It is good to start from the very basics, and this cartoon shows us, if we divide the heart into the left and the right, how it would look like. And we see these 3 points. The one on the right is the arrow on the right points to the post capillary portion, the one in the middle to the capillary portion, and the one on the left side to the pre-capillary portion. So we have, if we have the disease of, the basic feature is that the first thing is that the mean pulmonary artery pressure has to be high. The second thing is that there can be problems at the post-capillary end over here, or it can be with pre-capillary end, or it can be both. So when we talk of left heart disease, we really are talking of conditions where, the most common way that we have hypertension because of left heart disease, it is because the left ventricular end diastolic pressure rises, so the left atrial pressure rises, and then we have pulmonary venous hypertension. And these are the important causes that have been highlighted in this. We also need to understand that a rare but very pertinent cause is the disease in the pulmonary veins. And as we shall see in one of the slides, this really leads to a lot of problem. On the other hand, if we have disease primarily in the pre-capillary portion, we have the type 1 pulmonary hypertension. So this is it. Between the most important step, they say, one of the first steps in management of pulmonary hypertension is to be able to distinguish between pulmonary arterial hypertension and pulmonary venous hypertension. And so as we see here, the right ventricular size, the left atrial size, the interatrial septal bulge, the flow pattern of the pulmonary artery, features like EA ratio and E to E prime ratios, they all help us to distinguish between pulmonary arterial and pulmonary venous hypertension. So pulmonary hypertension in left heart disease is essentially elevated pulmonary pressure in response to an elevated left atrial pressure. It is a complex condition. However, there are 3 main groups, as has been highlighted here, and they can be associated with heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction, or valvular heart diseases. Now, when we see these 3 groups, you may not have pulmonary hypertension, but when you have pulmonary hypertension, it can be isolated post-capillary pulmonary hypertension, wherein you have elevated pulmonary capillary wedge pressure, but the DPG, that is the diastolic pressure gradient, and the pulmonary vascular resistance both are narrowed. You can have combined post-capillary resistance, wherein you have a raised diastolic pulmonary gradient, and this particular definition actually has been introduced as late as about 3 years ago, or it may be associated with or may have only elevated pulmonary vascular resistance. Now, how do you go about? There are what we call as clinical phenotypes, and we can see here the clinical phenotypes may have probabilities which may vary from high to intermediate to low. So you can have possibilities of a patient having pulmonary hypertension in left heart disease based on the pre-test probabilities. There are essentially 3 types. So you have elderly patients who may have 2 or more of obesity, hypertension, diabetes, dyslipidemia, etc. And they usually have atrial fibrillation associated with them, and they have ECG abnormalities in the form of LBB or LVH. So if your patient has a high probability, if the phenotype is high probability phenotype, then you treat these patients as left heart disease with pulmonary hypertension. Those who have low probability, they are kept on the other side. It is the intermediate type in whom it is really indicated to do right heart catheterization to see, that is to confirm the diagnosis. Of course, the gold standard remains cardiac catheterization. Some other important things in the hemodynamic evaluation, you evaluate them in stable conditions. You will evaluate the pulmonary artery wedge pressure at the end of expiration and in end diastole. If your patient is in atrial fibrillation, you diagnose it. You measure it 130 to 160 milliseconds later. In patients who have pulmonary wedge pressures which are between 13 to 15 millimeters, a fluid challenge is always a better way to diagnose rather than exercise testing. There are several measurements that need to be made, which include the transpulmonary gradient or diastolic pulmonary gradient or pulmonary vascular resistance or pulmonary compliance. All of these are highlighted here. What matters? What is important among these measurements? This is a very large study of 2,500 patients, which said that almost all of them are predictive of survival. However, there are other papers, including this registry from Vienna of over 3,000 patients, which said that diastolic pressure gradient is perhaps the single most important predictor of mortality and morbidity. So here we are when we have patients who have intermediate probability of having pulmonary hypertension due to left heart disease. You refer them for right heart catheterization at expert centers. And based on the further course that is highlighted here, one is able to categorize these patients as having pulmonary hypertension with HFrEF or HFpEF. It is very important to understand that HFpEF with pulmonary hypertension is a very problematic group because a lot of patients who have pulmonary hypertension can also have left heart disease concomitantly. So which is the culprit and which is the accompaniment? That is again a very difficult problem. There are other papers which have tried to highlight as to what is more important, whether it is the pulmonary vascular resistance or the diastolic pulmonary gradient. So in these studies, what they have done is they've taken patients with isolated post-capillary hypertension, combined post and pre-capillary hypertension, and those patients who had intermediate hypertension. That means one of the two, either the PVR or the diastolic pressure gradient was high. And what has been seen is that across the board, their weight increases as you move from isolated capillary pulmonary hypertension to intermediate to combined pulmonary hypertension. The weight increases. If you look at the measurements, almost all hemodynamic measurements progressively increase. And if we concentrate on the chart on the right side, we find that there is a statistically significant change in almost every value. The combined pulmonary hypertension actually behaves more like the idiopathic pulmonary arterial hypertension. And between the three, there is a progressive increase as you move from isolated capillary post-capillary pulmonary hypertension to intermediate group to combined pulmonary hypertension group. But as far as the multifactorial analysis is concerned, it found that only NT-proBNP and the pulmonary capacitance, that is, those are the two factors which are significantly associated. There are other papers which talk of, HFpEF and HFrEF and the mechanisms there too. And we understand that the mechanisms are different, although the end phenotypes are almost the same. And this is a paper which appeared last year in JACC, which talks of differences in mechanisms between HFpEF and HFrEF as the cause of this. There are a lot of phenotypes with left heart disease that we talk about. And this is a paper this is a paper which appeared a couple of years ago, in which you find that there are phenotypic domains and you have certain factors associated with phenotypes. What is important is that on the basis of these phenotypic factors, it is possible to divide these people into different phenotypic groups. It is very difficult to contain all these factors in one's heads, but it is important to remember that you can divide these patients into different phenotypic groups. There is also a pathological phenotype. And as we see here, what is highlighted in the red is actually the pulmonary venous occlusive disease. And what we find is that the highest degree of intimal and medial problems or thickening that you find is actually in the pulmonary veno-occlusive diseases. So there is a phenotyping on the basis of pathology also that is available for left heart diseases. These are not the only factors. There are other diseases. This is a paper from our group which appears in the JAPI of this month, and wherein we've examined the people who have class 3 or class 4 or class 5 chronic kidney disease, and we find that they also have associated pulmonary hypertension. Hypertension and associated left heart disease is important, but it is a multifactorial disease, but this is also probably one form of left heart disease contributing to pulmonary hypertension. And for the residents, I would like to say this is an article that my group has written on pulmonary arterial hypertension, which appears in the textbook of postgraduate medicine, which has again been come into the market this very month. So it will be a good read. I promise you guys that. And with that, I come. Thank you for your kind attention. Thank you very much.
Thank you, Sandeep. It was a good talk.